In the emergency department, 2 individuals came in. One of them is 12-year-old Timmy, who is severely dehydrated, presents with rapid and deep breaths, abdominal pain, nausea, and vomiting. On the clinical examination, his breath actually smells fruity and sweet. Timmy's parents say that he'd been eating a lot, but he'd actually lost a lot of weight. Also, they said that Timmy is also drinking water all the time and going to the bathroom a lot. The other person is 55-year-old Oliver, who also came in with severe dehydration, lethargy, and his family said he had a seizure about 2 hours ago. In the past month, he had lost some weight, although he had been eating. Both individuals underwent several investigations, including glucose levels, ketone bodies BMP, and an ABG. Based on both individuals' symptoms, we can assume that both suffer from diabetes mellitus. Diabetes mellitus is a condition where glucose can't be properly moved through the blood into the cells. This leads to high levels of glucose in the blood and not enough of it inside cells. Since cells need glucose as a source of energy, not letting glucose enter means that the cells starve for energy despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood with 2 hormones, insulin and glucagon. Both of these hormones are produced in the islets of Langerhans of the pancreas. Insulin is secreted by the beta cells, while glucagon is secreted by the alpha cells. Insulin reduces blood glucose levels. It does that by binding to insulin receptors embedded in the cell membrane of insulin-responsive tissues, like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing the glucose transporter that are inside the cell to fuse with the cell membrane, allowing glucose to be transported into the cell. Now, there are 2 types of diabetes mellitus, type 1 and type 2. And the main difference between them is the underlying mechanism that causes the blood glucose levels to rise. Let's start with type 1 diabetes mellitus, which is an autoimmune condition. See, autoimmune conditions sometimes happen together. So on the exam, the past medical history might include a history of autoimmune thyroid disease, like Hashimoto's thyroiditis, or vitiligo, or lupus. In type 1 diabetes, the immune system targets and destroys the beta cells of the pancreas. A common target is an enzyme inside beta cells called glutamic acid decarboxylase, which helps make gamma-aminobutyric acid, or GABA, which, among others, increases insulin release and also has a protective and regenerative effect on the beta cells. The high-yield fact to remember is that the antibodies against glutamic acid decarboxylase are called GAD antibodies. In addition, other antibodies like anti-islet cell antibodies can also be present. Without the protective and regenerative effect of GABA, the beta cells progressively decrease. Losing beta cells means less insulin, and less insulin means that glucose builds up in the blood because it can't enter the body's cells. Now, there is a gene complex involved in the regulation of the immune response, and this is called the human leukocyte antigen system, or HLA system. These genes code for the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. MHC is like the serving platter that antigens are presented to the immune cells. Interestingly, people with type 1 diabetes often have specific HLA genes in common, HLA-DR3 and HLA-DR4, both of which are high yield for your exams. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, and individuals present with symptoms of diabetes before the age of 30. In type 1 diabetes, the tissues are very sensitive to insulin, but since there are less beta cells, insulin levels are low. On histology, there's usually an islet leukocytic infiltrate. There are 4 clinical symptoms of uncontrolled diabetes. There's polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it can't get into cells, which leaves cells starved for energy. So, in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, called proteolysis, both of which results in weight loss for someone with uncontrolled diabetes. This catabolism leads to polyphagia. Now, with high glucose levels, when blood gets filtered through the kidneys, some of it starts to spill into the urine, and this is called glycosuria. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated, resulting in polydipsia. Now, let's move on to type 2 diabetes mellitus. In type 2 diabetes, the body makes insulin, but the tissues don't respond to it as well. The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to the membrane. This is called insulin resistance. The most important risk factor for insulin resistance is obesity. Apart from this, there are also some genetic factors involved. We see this when we look at twin studies as well, where having a twin with type 2 diabetes increases the risk of developing type 2 diabetes, completely independent of other environmental risk factors. In type 2 diabetes, since tissues don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effect and move glucose out of the blood. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal. This beta cell compensation, though, isn't sustainable, and over time, these overworked beta cells get exhausted and eventually die off. When this happens, insulin levels will start decreasing. So remember that the serum levels of insulin in type 2 diabetes is variable depending on when it's diagnosed. Now, along with insulin, beta cells also secrete amyloid polypeptide. So while beta cells are cranking out insulin, they also secrete an increased amount of amyloid polypeptide. Over time, amyloid polypeptide builds up and aggregates in the islets. So on histology, there will be amyloid polypeptide deposits in the pancreas, along with a variable number of beta cells, depending on when it's diagnosed. Now, type 2 diabetes usually appears after the age of 40, and presents similarly as type 1 diabetes with polydipsia, polyuria, polyphagia, and weight loss. Diagnosing type 1 or type 2 diabetes is done by getting a sense for how much glucose is floating around in the blood. Very commonly, a fasting glucose test is taken, where the person doesn't eat or drink, except water, that's okay, for 8 hours, and has their blood tested for glucose levels. A level of 126 milligrams per deciliter or higher indicates diabetes. A non-fasting or random glucose test can be done at any time, with 200 milligrams per deciliter or higher being diagnostic for diabetes if the individual has symptoms. Another test is called an oral glucose tolerance test, where a person is given glucose, and then blood samples are taken at time intervals to figure out how well it's being cleared from the blood. A glucose level over 200 milligrams per deciliter after 2 hours indicates diabetes. Okay, so when blood glucose levels get high, the glucose can also stick to proteins that are floating around in the blood or cells. So that brings us to the HbA1c test, which tests for the proportion of hemoglobin in red blood cells that have glucose stuck to it, or glycated hemoglobin. HbA1c levels of 6.5% or higher indicates diabetes. This proportion of glycated hemoglobin doesn't change day to day. So a high-yield fact is that this test gives a sense for whether the blood glucose levels have been high over the past 3 months, which is the lifespan of a typical red blood cell. Regarding treatment, in type 1 diabetes, insulin is always necessary because of decreased endogenous production. While in type 2 diabetes, lifestyle modifications like exercise and dietary changes are first line. In addition, oral medications like metformin are the first-line pharmacologic intervention in type 2 diabetes, with insulin being an option if oral medications fail to control glucose levels. It's also important to treat and prevent complications in diabetes. For example, ACE inhibitors and ARBs have been shown to decrease the risk of diabetic nephropathy in diabetic individuals with hypertension. In addition, yearly eye exams, urine microalbumin testing, and foot exams should be done. Now, let's go over one very high-yield acute complication of diabetes that usually happens with type 1 diabetes, and it's called diabetic ketoacidosis, or DKA. This usually happens when individuals aren't rigorous with their insulin therapy, or when the body is really stressed and needs more insulin, like during an infection. To understand it, let's go back to the process of lipolysis, where fat is broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies, like acetoacetic acid and beta-hydroxybutyric acid. These ketone bodies are important because they can be used by cells for energy, but they also increase the acidity of the blood, which is why it's called ketoacidosis, which is a type of metabolic acidosis. Now, this doesn't typically happen in type 2 diabetes because there's usually some level of endogenous insulin that prevents lipolysis. Clinically, individuals with DKA are dehydrated because a lot of glucose is lost through urine, and they can develop Kussmaul respiration, which is a deep and rapid breathing as the body tries to move carbon dioxide out of the blood in an effort to reduce its acidity. Their breath also smells sweet and fruity because ketone bodies break down into acetone, which escape as a gas during exhalation. Abdominal pain, nausea, vomiting, and in severe DKA, mental status changes like delirium and psychosis can occur. Complications of DKA include acute cerebral edema, which is when there's too much fluid in the intra- or extracellular space. In the case of DKA, there's too much fluid in the extracellular space of the brain because glucose basically drags water out of the cells. Other complications include cardiac arrhythmias due to potassium imbalance, which can lead to heart failure. And finally, since people with DKA have poorly controlled diabetes, their immune system is also likely to be compromised. This means they are more vulnerable to common infections like Candida, but also some that only affects people with immune deficiencies. One of these is mucormycosis, a life-threatening fungal infection caused by Rhizopus species that starts in the sinuses but can spread to the brain. Lab results show hyperglycemia and signs of metabolic acidosis, which is low pH levels and low levels of bicarbonate, or HCO3. The anion gap is high, which reflects a large difference in the unmeasured negative and positive ions in the serum, largely due to this buildup of keto acids. Blood ketone levels are also high, and if there's a concomitant infection, then leukocytosis can also be present. Now let's focus a bit for the next part. Cells have a transporter that exchanges hydrogen ions for potassium. When the blood gets acidic, there's a lot of positively charged hydrogen ions floating around. Cells will exchange these extracellular protons with intracellular potassium. So at first, there will be hyperkalemia. Next, in addition to helping glucose enter cells, insulin also stimulates the sodium-potassium ATPases, which help potassium get into cells. And, so without insulin, more potassium stays in the extracellular fluid. Since all this potassium is eventually excreted, even though the blood potassium levels remain high, overall stores of potassium in the body starts to run low, and in this way, total body potassium is depleted. Treatment of DKA relies on IV fluids to correct dehydration, IV insulin, and potassium. Sometimes to prevent overcorrecting the hyperglycemia, a small amount of dextrose is given with the insulin. One high-yield acute complication that usually happens with type 2 diabetes is hyperosmolar hyperglycemic state, which is when levels of glucose are really high and it leads to extreme dehydration. To help understand this, remember that glucose is a polar molecule that cannot passively diffuse across cell membranes, which means that it acts as a solute. So, when levels of glucose are super high in the body, that means it's in a hyperosmolar state. So water begins to leave the body's cells and enter the blood vessels, leaving the cells relatively dry and shriveled. Blood vessels that are full of water leads to polyuria and dehydration. And this is a very serious situation because severe dehydration affects the brain, leading to various symptoms like lethargy and focal neurological deficits like seizures, which can progress to coma and death if left untreated. Labs show hyperglycemia, often over 600 milligrams per deciliter, high serum osmolality, often over 320 milliosmoles per kilogram, and, unlike DKA, there's no acidosis, because ketone production is limited by the endogenous insulin. Treatment relies on a lot of IV fluids and insulin therapy. Another important complication associated with the treatment of diabetes is hypoglycemia. This is usually related to insulin, but can also be caused by oral medications, like sulfonylureas. Recall that the brain depends on glucose for its energy, so hypoglycemia is extremely dangerous, as it can lead to irreversible damage to the neurons. The symptoms of hypoglycemia include symptoms of autonomic system activation, such as palpitations, sweating, shaking, nausea, and of course hunger. The more dangerous symptoms are called neuroglycopenic symptoms, which include focal neurological deficit, mental confusion, and coma. Now, exams like to test your ability to differentiate hypoglycemia caused by injecting insulin from that caused by insulomas or sulfonylureas. To do this, we measure serum levels of insulin and C-peptide, an endogenous byproduct of insulin production in the beta cells. High insulin levels but low C-peptide means the hypoglycemia is caused by exogenous insulin. On the other hand, high insulin and high C-peptide levels indicate that the problem is coming from an insulinoma, an insulin-producing beta cell tumor. Sulfonylureas also result in a similar biochemical profile, as the beta cells normally respond to hypoglycemia by increasing insulin production. Now, there are some chronic complications of diabetes, which can happen with both type 1 and type 2 diabetes. The two basic mechanisms are non-enzymatic glycosylation, or NEG, and osmotic cellular damage. Non-enzymatic glycosylation occurs when glucose covalently attaches to cell proteins and lipids without the help of an enzyme. These sugar-coated molecules are pro-inflammatory and can cause damage to the cell. NEG in small blood vessels, like arterioles, cause hyaline arteriosclerosis, where the walls of arterioles develop protein deposits that make them hard and inflexible. In addition, the basement membrane can thicken and make it hard for oxygen to easily move into the tissues, causing hypoxia. In the eyes, it can lead to retinopathy. A fundoscopic exam will show cotton wool spots, flare hemorrhages, and microaneurysms. In the kidneys, the afferent and efferent arterioles, as well as the glomerulus itself, can get damaged, which can lead to nodular glomerulosclerosis. On histology, there's Kimmel-Steele-Wilson nodules, which are clumps of hyaline material found in glomerular capillaries. In the early stages of diabetic nephropathy, small amounts of albumin leak through the glomerular barrier and into the urine. This is called microalbuminuria, and it's the earliest sign of diabetic nephropathy, which can eventually progress to chronic kidney disease. When NAG occurs in medium and large arterial walls, it can lead to atherosclerosis, which can affect multiple vessels, like the coronary arteries of the heart, causing coronary artery disease, or CAD. This is the major cause of death in diabetics. It can also affect the arteries in the legs, causing peripheral vascular occlusive disease, which can lead to gangrene and even limb loss. Finally, it can affect the tiny arteries in the brain, leading to cerebrovascular disease and strokes. The next mechanism is osmotic cellular damage. Normally, when glucose enters cells, it can be converted into an alcohol called sorbitol by the enzyme aldose reductase. The problem is that sorbitol is an osmotic agent, meaning it attracts water, but here the water is going into the cells. As a protective mechanism, some cells are able to convert sorbitol to fructose with the enzyme sorbitol dehydrogenase. But the cells of the lens, the pericytes in the retina, Schwann cells, and renal epithelial cells lack this enzyme. So in the lens, sorbitol builds up, causing cataracts. Damage to the Schwann cells decreases the myelination of sensory and autonomic nerve fibers, causing diabetic neuropathy, which manifests in a stocking glove distribution. This makes these parts of the body more prone to injury, and they can often develop foot ulcers as a result of chronic damage. This is made worse by the fact that they will also have impaired healing due to hyperglycemia. Autonomic neuropathy can cause diabetic gastroparesis, which is weakness of the gastric peristalsis that results in vomiting after meals and constipation. Besides type 1 and type 2 diabetes, there are also a couple of other subtypes of diabetes mellitus. An important one that's commonly tested is gestational diabetes, which is when pregnant women have increased blood glucose, especially during the third trimester. This occurs because the placenta releases large amounts of human placental lactogen, which is thought to induce insulin resistance. Some mothers might not be able to produce enough insulin to overcome the effect of this placental hormone, so blood glucose goes up and signs of diabetes manifests. Diabetes can also occur secondary to some systemic disorders, like Cushing's syndrome, and medications like glucocorticoids. This is because corticosteroids also cause insulin resistance. Alright, as a quick recap, type 1 diabetes mellitus is an autoimmune condition that's associated with HLA DR3 and DR4. It causes the destruction of beta cells by autoantibodies, and this usually starts before the age of 30. The tissues are very sensitive to insulin, but insulin levels are low. In type 2 diabetes mellitus, there's insulin resistance. Risk factors for type 2 diabetes are obesity and various genetic factors. Insulin levels are increased at the start, but as the islet cells tire out and die, the level drops. Type 2 diabetes usually manifests after the age of 40 and presents similarly as type 1 diabetes with symptoms like glucosuria, polyuria, polydipsia, polyphagia, and unintentional weight loss. To diagnose diabetes, a fasting glucose, a non-fasting glucose, or the oral glucose tolerance test can be done. However, HbA1c gives a better sense of blood glucose levels over the past 3 months. One important acute complication of type 1 diabetes is DKA, which presents with dehydration, Kussmaul respiration, sweet and fruity breath, abdominal pain, nausea, vomiting, and mental status changes like delirium and psychosis. These people will have metabolic acidosis and hyperkalemia with reduced total body potassium. An acute complication of type 2 diabetes is hyperosmolar hyperglycemic state, characterized by dehydration due to high serum osmolarity. The cause is severe hyperglycemia, but there's no metabolic acidosis since ketones are not generated. Some of the important chronic complications of diabetes include small vessel disease, which can affect the eyes or the kidneys, atherosclerosis, which can lead to CAD, peripheral vascular occlusive disease, and cerebrovascular disease, and neurological problems like paresthesia in a glove and stocking distribution. Okay, back to our cases. Timmy came in severely dehydrated, and he had rapid and deep breaths, which is indicative of Kussmaul respiration. His breath had a sweet and fruity odor due to acetone from ketone body metabolism. All of these point to DKA. The lab results showing high levels of glucose, low pH with low bicarbonate levels, and a high anion gap, increased blood ketone levels, and hyperkalemia confirms this. His parents said that he's been eating a lot lately, but actually lost weight, meaning he has polyphagia with weight loss. He also had polydipsia and polyuria, and these are all symptoms of diabetes mellitus. Due to his age and the presence of DKA, he most likely has a cause of previously undiagnosed type 1 diabetes. Now, Timmy has received a lot of fluids and insulin, and after making him feel better, more tests have been done, like a fasting glucose and GAD antibodies test to confirm the diagnosis. Next, we have Oliver, who came in with severe dehydration, lethargy, and seizures. Labs show really high levels of glucose, above 600 milligrams per deciliter, but no acidosis or ketone bodies. His serum osmolality was over 320 milliosmoles per kilogram. All this indicates hyperosmolar hyperglycemic coma, which is usually a complication of type 2 diabetes. Oliver has been treated with IV fluids and insulin with dextrose. Further tests like a fasting glucose and HbA1c test need to be done to confirm type 2 diabetes.